Yes, hello and good evening, everyone. The White Army is blessed to have Professor Sreenivas sir as our teacher and mentor. Dr. Sreenivas sir has completed his MBBS and DM Neurology from Ramchandra Medical College, Chennai, and he has graduated in General Medicine from Manipal Academy of Higher Education. Dr. Sreenivas sir was a passionate teacher, and he is known for his clinical acumen. And he is also an author of the book Focussed Neurology, which covers all the important concepts for both undergraduates and postgraduates, which is very helpful for all students preparing for exams. We welcome you, sir, to the White Army, and also welcome all the active members to this session. With the permission of Sreenivas sir, can we please begin the session, sir?
Sorry to interrupt, Sreenivas sir, once again. Thank you, Nitish, for that kind introduction of sir. Today's session will be hosted and moderated by Dr. Vijay Balaji, third year MD General Medicine student from MSRMC, Bangalore. And when we requested the Srinivasan sir today to take a class on neurology, he readily agreed, and he has taken out his valuable time to teach the members of White Army today. He's an authority in the field of neurology. He has written his own book, Focussed Neurology. So whatever he's teaching us today is all from his experience and also the vast knowledge in the field of neurology. So it's a great privilege and also a kind of blessing for all the members of White Army today to directly hear from the author himself. So once again, on behalf of all the members, I cordially welcome to you, sir, for this session. Thank you so much.
Thank you for the nice introduction, Doctor. Can I start?
Please, sir, please.
Yeah. At the outset, I would like to thank the White Army for the wonderful and excellent opportunity they have given me to address the elite gathering across the country, especially Dr. Kishan, who was instrumental in bringing me to this platform. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhrapradesh, India. I'm also the medical author of the book Focussed Neurology. Almost all the important points of neurology, I put it in a question and answer format in a book useful for students both at undergraduate and a postgraduate level. Since it's a question and answer format, it will be very, very useful. And this book can be bought online from all the leading shops, including Amazon. So today's topic will be consciousness, coma, and brain death. And I think this topic is going to be really useful for MBBS students who are doing night duties and MD general medicine students who see day in and day out the comatose patients and the difficulties they face to address persons, whether they have gone into a state of brain death or not. Not only MBBS and MD students and other specialities, postgraduate students belonging to other specialties, but also I think it will be useful for dental students, physiotherapy, nursing, because it's such a common topic that everyone has to know about it. Consciousness, coma, and brain death. Sreenivas, consultant neurologist. Yeah, first of all, again, I would like to thank from the bottom of my heart, Dr. Kishan Rao, MBBS and super specialty in cardiothoracic vascular surgery. He's a founder and chief of the White Army. Thanks a lot, sir, for giving me such a wonderful opportunity. And I've seen your motto, very interesting. Help others to help ourselves. I think you have a very social commitment also. That's a very nice gesture. Yeah, as I said, and as all the people have introduced me, I'm the medical author of the book Focussed Neurology. It's available online from all bookshops, including Amazon. I put all the questions, all the important topics in a question and answer format. It is published by one of the leading publishers and distributors, CBS Publishers and Distributors. It has become immensely popular with the students so that it has gone for a reprint within 3 years of its publication. Yeah, I also have my own YouTube channel, Dr. Sreenivas Medical Concepts, where I have uploaded more than 200 plus neurology videos, and I have more than 5,000 subscribers. So any doubts, any clarification, you can always refer to my YouTube channel with 200 plus neurology videos, completely free. All you need to do is to subscribe and then just follow my channel. Yeah, and all the important points and all the important topics I've covered. In fact, I'm planning to soon take on more important topics. Right, these are the various felicitations I've got. My book is kept in the Christian Medical College Vellore Library also. So that's one of the important achievements I've got. Yeah, this is coming to the topic consciousness, coma, and brain death, the important concepts. I've always been stressing concepts only. In fact, the name of my YouTube channel is also Dr. Sreenivas Medical Concepts. I don't want to talk about all the theoretical points in length that can be got from any textbooks. My focus is always on the concepts. In fact, that's why the name also Focussed Neurology, the name of my book. So today also, I'll be talking all the important concepts, and I'm sure that at the end of the session, you will go with a good knowledge of consciousness, coma, and brain death. All I need is 1.5 hours of your patient listening. Any questions, clarification, doubts, I'm willing to take. All you need to is to post onto the chat box your comments. My email ID is sreeklpm@gmail.com, and my own YouTube channel is Dr. Sreenivas Medical Concepts. Right. Consciousness and coma, the important concepts. Coma is a deep sleep-like state from which the patient cannot be aroused. The consciousness has two qualities. One, arousal or alertness. It is a primitive function sustained by the brainstem. So arousal or alertness, the moment you wake up a person, if he's able to get up, he's alert and arousal is there, that means his brainstem is functioning well. That's a primitive function sustained by brainstem. The second important quality is cognitions, coherence of thought, requires an intact cerebral cortex. So consciousness has got two important qualities: arousal or alertness, which is a primitive function sustained by the brainstem, and the cognition, the coherence of thought, which requires an intact cerebral cortex. Consciousness. How are we in a state of consciousness? What is it which is making us all to be in a conscious state? The maintenance of consciousness is by a special thalamocortical alerting system termed the reticular activating system, RAS, which is diffusely located in the brainstem and projecting to both the cerebral cortices. This is a very important clinical concept. The RAS is in the brainstem but projects into both the cortices. Why is it important? I'll be telling you now. Yeah, you can see here the RAS system, reticular activating system, coming in the brainstem and going to the cortices. Right. So as long as this RAS system or the reticular activating system is intact, person is in a conscious state. The moment RAS gets disrupted, person starts losing consciousness. So reticular activating system is the system for all of us to be in an awake state. So coma can be produced if the RAS system gets affected. It could be a structural cause or a metabolic cause. Structural cause means cerebral infarct, hemorrhage, spontaneous hemorrhage, whatever may be the reason. Metabolic cause means like hypoglycemia, hyponatremia. A very important clinical point is that structural cause of coma is because of damage to both the cerebral hemispheres or the brainstem. I repeat, the structural cause of coma is because of the damage of the reticular activating system to both the cerebral cortices or the brainstem. If one cerebral cortex gets affected, person does not lose consciousness. If RAS system of one cerebral cortex gets affected, person does not lose consciousness. Why? There is other cortex to take over, because RAS system comes from the brainstem and goes to both the cortices. Very important clinical point. That's why a person may be having a big tumor on one side or big MCA infarct on one side, but person does not lose consciousness. He's awake and he talks to everyone. Whereas hypoglycemia, just a decrease in blood sugar, will affect RAS in a diffuse manner and person loses consciousness. So for a person to lose consciousness, both the cortices should get affected. For example, if it is only MCA infarct on one side, person does not lose consciousness unless there's a massive cerebral edema going and compressing the other cortex, or the infarct spreads, or there's a shift of the cerebral structures and the other cortex gets involved. Both the cortices should get involved for a person to lose consciousness. If only one cortex gets affected, person does not lose consciousness. That's why in stroke wards, in patients, we see so many persons with stroke, massive MCA infarct, he does not lose consciousness. So for a person to lose consciousness, RAS, the both cortices should get affected. If only one cortex gets affected, person does not lose consciousness. Very important point. Or brainstem, even if it gets affected, person loses consciousness because the RA is so close together in the brainstem, but goes diffusely to both the cortexes. So if RA system gets affected in a small area like brainstem, like Fontaine hemorrhage, person loses consciousness. So the RA should get affected either in the brainstem or both the cortices. This is about the structural cause of coma. So infarct, hemorrhage, tumor, whatever could be structural reason. Not only a structural disruption of the RAS, but even a metabolic impairment of the RAS or a functional impairment of the RAS, person may lose consciousness because the brain and the cerebral neurons depend so much on oxygen and glucose for its survival that the moment they are deprived of oxygen and glucose, the neurons get affected. So suppression of the reticular cerebral function by drugs, for example, anesthetic drugs, it goes and suppresses, affects the functional performance of the RAS. There's a functional impairment of the RAS, person loses consciousness. Toxins goes, affects the RAS, person loses consciousness. Metabolic derangements such as hypoglycemia. As I said, brain depends so much on oxygen and glucose that if there is hypoglycemia, RAS becomes ineffective and person loses consciousness. Or anoxia, decreased oxygen to the RAS, person loses consciousness. Uremia, renal failure, hepatic failure, ammonia accumulates, it affects the RAS. Whatever may be the mechanism, whatever may be the substance, the final outcome is that impairment of consciousness because of the metabolic derangement affecting the effective functioning of the RAS. Here I would like to stress one important point. Note, metabolic causes of coma are far more common than structural causes. Metabolic causes of coma are far more common than structural causes. And one of the important metabolic causes of coma is hypoglycemia. We should always remember that one of the most common causes and highly treatable condition is hypoglycemia. So whenever a person in a comatose state comes to casualty, the first thing we should always consider is hypoglycemia. Because hypoglycemia, every second counts, it's killing the person. And the moment you start pumping in dextrose, person is going to recover. Highly treatable condition, you'll feel so much of satisfaction. The person who is in a comatose state, you start giving dextrose, even before you complete giving the dextrose, person sits up and starts talking to his attendants. You get the joy of treating the person and the joy of being a doctor. Hypoglycemia is a wonderful condition to treat and make the person better. 2 points to be considered in a hypoglycemic coma. One, person in a comatose state, but there's a history of diabetes. Then should we give dextrose or not? Because hypoglycemia is one of the important causes of coma. We have to give hypoglycemia because hypoglycemia is more dangerous than hyperglycemia. Hypoglycemia is killing the person. So what we do when there's a history of diabetes, we take the blood out, send to the lab for assessment, and immediately give dextrose. If it's going to be hypoglycemia, it's going to get corrected. Person is going to come out of coma. God forbid, if it's going to be hyperglycemia, diabetes state, you get the sugar level, give always insulin and the sugar going to come down. So whether a diabetic history is there or not, a person in a comatose state, we have to proceed and treat as hypoglycemia and give dextrose. Another important point to be noted is that all persons in a comatose state, we have to suspect hypoglycemia and give dextrose. But a word of caution, Persons who are alcoholic and come in a comatose state, yes, he may be hypoglycemic, and then you give dextrose. But alcohol, they don't take food well, and on top of it, they are deprived of thiamine. They have vitamin B1 deficiency, thiamine deficiency. So a person who is already deprived of thiamine, who is already thiamine deficient, if we start giving dextrose, whatever little thiamine is left out, that is also utilized by dextrose, and we are pushing the persons to develop Wernicke's encephalopathy. We are pushing the persons to develop Wernicke's encephalopathy because we are giving dextrose. Whatever little thiamine is left out, that is also being utilized. So for all persons who come in a comatose state, suspect hypoglycemia, give dextrose. But a word of caution: a person who comes with a history of alcoholism, always give thiamine, wherein 50 milligrams IV, and then give dextrose. Very important point. And as I said, metabolic causes of coma are far, far more common than structural causes. We should always suspect metabolic causes of coma than structural causes of coma. As I said, I'm very much interested in asking questions and then giving answers. I like this question and answer format because so much of information can be got in very little time. Instead of talking all theoretical points, question and answer format is the format I prefer. So whenever an opportunity comes, I try to put it in a question and answer format. Here comes one question. Why antihistamines and anticholinergic drugs produce sleep as side effect? We take antihistamines, chlorpheniramine maleate, he takes, and after some time you see him drowsy and lying. Or anticholinergics, amitriptyline we give. Person develops drowsiness and he starts. That's why amitriptyline generally we prefer to give in the night time so that he gets drowsiness and he sleeps off. As this morning, if he sleeps, he may get involved in an accident. So why should antihistamines and anticholinergics bring down the conscious level, produce sleep as side effect? The answer is the fibers in the reticular activating system are histaminergic, cholinergic, adrenergic, dopaminergic, and serotonergic. So the fibers in the RA are histaminergic, cholinergic, adrenergic, dopaminergic, and serotonergic. So stimulation of the RAS produces arousal, and the inhibition of the RAS by antihistamines and anticholinergics therefore produce sleep as side effect. So histaminergic and cholinergics are stimulants. When we give antihistamines and anticholinergics, they are effective. They are affecting the effective functioning of the RAS, and therefore person gets sleep as side effect. Very important. Therefore, when we give drugs like antihistamines and anticholinergic, we should always warn the patient that he is likely to develop sleep, and therefore he has to take adequate precautions. Right. History and examination, very, very important. In fact, I would, if the White Army gives me a chance, I would love to talk about history taking in neurology, examination in neurology, and localization in neurology. Very, very important. Whatever may be the advent of these latest gadgets, investigations, it is still the history and examination which are very, very important, especially for neurological disorders. For sleep, history is important. For epilepsy, history is important. For headache, history is important. You cannot go ahead without taking adequate history. In fact, you have to keep listening to the patient. He is telling you the diagnosis. Listen to the patient. He is telling you the diagnosis. You not break your head. What is his diagnosis? Just keep listening to the patient. He is telling you the diagnosis. Quote, listen to the patient. He is telling you the diagnosis. Unquote, Sir William Oscar. So always try to get good historical points and clinch the diagnosis because he himself is telling the diagnosis. So in a comatose patient, what are all the important points in history taking? Person is comatose, but comes with sudden onset. We have to suspect subarachnoid hemorrhage. Aneurysms are there. It can suddenly rupture and person can go into comatose state. Aneurysm rupture, especially with physical exertion. He might be involved in games or with a physical relationship. Aneurysm ruptures and person suddenly develops goes into a state of coma. So sudden onset, always suspect subarachnoid hemorrhage, get back to the history. In fact, I can tell one important and very interesting example. In our medical college where I work, one young boy was brought to the casualty in a comatose state. And his father was telling that he was pampered, so he's maligning, he's trying to act that he is in a comatose state, but probably is not. So some of us were thinking that, oh, is it historical? But then one good history point, we clinched the diagnosis. He was playing football. He was playing football well, and then suddenly he became unconscious. So we're thinking that probably he might have had aneurysm. He was exerting himself, physically exerting himself. Probably the aneurysm would have ruptured, and we took him for angio, and it confirmed the diagnosis. So history is very important. If you had not got this history, you would have missed the person, we would have missed the diagnosis, and we would have lost the patient. Just because we got a good historical point, we could save the person immediately. We call the neurosurgeon, surgery was done, and person survived. So history taking is going to be very, very essential. Seizures, post-ictal confusion, post-ictal drowsiness, and person may slowly lose consciousness. They may develop weakness also, Todd's palsy. So there's a sudden onset subarachnoid hemorrhage seizure. Gradual or fluctuating onset, we have to suspect subdural hematoma, metabolic encephalopathy. A very important point here about subdural hematoma is that when there is history of head injury, either an artery can rupture. Example, middle meningeal artery can rupture and produce extradural hematoma. Extradural hematoma is because of an arterial bleed, torrential bleed, massive bleed, but it will be confined to a particular position because the dura will not allow the blood to expand. So it will be well localized. Subdural hematoma is a venous bleed. A vein slightly gets torn and blood slowly starts trickling in. So subdural hematoma is a venous bleed, but it is under the dura, so it is spread out right from the front to the back of the cortex. That is subdural hematoma. Extradural hematoma, you have to be very careful because such a torrential bleed. Take a CT scan, call the neurosurgeon, take the hematoma out, and the person is going to survive. Especially you have to look at the size of the pupils because extradural hematoma can go and compress the midbrain, the parasympathetic fibers running superficially on the third nerve. So asymmetry of the pupil, anisocoria, suspect extradural hematoma, take a CT, call the neurosurgeon. Fine. Subdural hematoma is a very slow process, gradual process. In fact, there are instances where old people would have sustained a trivial injury, minor injury, might have had a trivial injury. The veins would have torn and slow bleed must have been occurring for the last few days or weeks. Person might have even forgotten the injury. He comes to the doctor, says he is, and the patient's attendant says that he's forgetting, he's developed dementia. He was all right a few months ago. And we ask history may not be forthcoming. He may not volunteer because he thinks it's a trivial injury. It might not have caused a real neurological deficit. But that trivial injury is sufficient, especially in old people, to rupture the small vein and cause blood trickling down. So we have to take CT scan, and the moment we find subdural hematoma, very good for the doctor and very good for the patient, because the moment you take the hematoma out, person memory comes back. In fact, subdural hematoma is one of the important treatable causes of dementia. So gradual fluctuating onset subdural hematoma, blood slowly trickling, so it takes a lot of time to develop an unconscious state. Premonitory transient symptoms, TIA, transient ischemic attack. Again, I always insist, history taking is of paramount importance. TIA, internal carotid artery, ophthalmic artery, they may develop amaurosis fugax, vision loss like a curtain coming from top to the bottom. If that is the history forthcoming from the patient, you have to suspect amaurosis fugax, internal carotid artery stenosis, ophthalmic artery, and person is having a loss of vision. Transient ischemic attack. Immediately you put him on antiplatelets, get the internal carotid artery, angio or Doppler, CT scan, start antiplatelets, and you're going to save him from getting a catastrophic stroke. So there are premonitory symptoms like like amaurosis fugax, very important. That probably would have thrown embolus, and then person might have gone a big neurological deficit and comatose state. Very important point. Focal signs preceding loss of consciousness. If there are focal signs preceding loss of consciousness, it would be a structural cause. For example, a hematoma going encompassing the midbrain, one side pupil is normal, the other side pupil is dilated. Or hematoma going encompassing the corticospinal tract in the midbrain, there will be opposite side hemiparesis. One side focal always suspects structural cause. Whereas if it's a metabolic cause, it will be generalized. Hypoglycemia, hyponatremia, it will be generalized. So generalized always in favor of metabolic, focal always in favor of structural cause. Very, very important. And another important point is that structural usually affects the pupil. Metabolic usually spares the pupil. There will be generalized deficits. Second important point is that if the person is able to, though he's in a confused state, but is still able to respond and obey the commands, always test for asterixes. Ask him to extend the hand and see and dorsiflex the hand and then leave it. If it falls, tries to correct, falls, tries to correct, that is bilateral asterixes, is a sign of metabolic encephalopathy. It is because of these substances, neurotoxins, which go and affect the posterior column in the parietal lobe. The position joint sense is affected, so he's not able to maintain a position. It falls, he tries to correct it, falls, he tries to correct. He's not able to maintain a position. That's known as asterixes. So if there is bilateral asterixes, it is a sign of metabolic encephalopathy. If pupils are involved, it is a sign of a structural cause of coma. And focal signs preceding LOC, structural cause. Generalized signs preceding LOC, it's a metabolic process. If there's a history of fever, suspect infectious process, encephalitis, herpes simplex encephalitis, meningoencephalitis. Intracranial hemorrhage, suddenly there's hemorrhage, there'll be history of falls. The person is in a confused state, metabolic toxic etiology. They start slowly. Metabolic encephalopathy, one more important point, it's in a state of continuum. Person is completely all right, completely conscious, fully conscious, becomes drowsy, slowly disoriented, stuporous, comatose. It's a continuum stage, goes slowly and gradually in metabolic encephalopathy or toxic encephalopathy. But a structural cause, hemorrhage, sudden loss of consciousness. So if it is a gradual, a continuum, a spectrum is produced, suspect a metabolic or toxic etiology. Confusion, slowly, coma, alert, drowsy, confused, stuporous, confused, metabolic toxic etiology. Of course, history of trauma, cardiac arrest, and drug ingestion will be obvious. Right. This is about history, general examination. Check out the pulse, bradycardia. If there's bradycardia, it could be heart diseases, intoxication. But from the neurologic point of view, always suspect raised intracranial pressure. It causes a characteristic triad, Cushing's triad, wherein there is bradycardia. So body tries to compensate, but by increasing the blood pressure, so there will be hypertension and irregular respiration. It indicates a sign of raised ICP, impending disaster, Cushing's reflex. So bradycardia means it's going to be dangerous for the person. So bradycardia, it could be raised ICP, intoxications, or heart disease. If there's tachycardia, on the other hand, it could be because of infections or hypovolemia. You have to check the blood pressure. If there is hypotension, it could be myocardial infarction, intoxications like ethyl alcohol, barbiturates, sepsis. If it is hypertension, it could be increased intracranial pressure. That's what I said. Body is trying to compensate by increasing the blood pressure. So hypertension, bradycardia, irregular respiration, suspect the Cushing's triad, raised ICP. Hypertension can also cause intracerebral hemorrhage and renal diseases. One important point, important concept. I stress always on concept. If we find hemorrhage in putamen, pons, thalamus, and cerebellum, it is hypertensive bleed. We not also really investigate or evaluate the person. It is confirmed. If you find bleed in putamen, pons, thalamus, cerebellum, it is hypertensive bleed. If you find bleed in other places rather than these four sites, it is non-hypertensive bleed. It could be AV malformation or aneurysm. Why hypertension has got predilection for these 4 points, 4 areas, putamen, pons, thalamus, and cerebellum. These are end points, end arteries. Hypertension can produce 2 types of disease. One, lipohyalinosis and cause lacunar infarction, or Charcot-Bouchard aneurysm, end arteries rupture, causing hemorrhage. So if you find hemorrhage in putamen, pons, thalamus, and cerebellum, it is a hypertensive bleed. We have to control the hypertension, give antiedema like mannitol. Breath order. If there is acetone, it could be diabetic ketoacidosis, ethyl alcohol, fetal hepaticus, uriniferous uremia, garlic order, arsenic poisoning. If a person has got hyperventilation, it could be because of hypoxia or hypercapnia, acidosis, or sepsis. If a person has got hypoventilation, it could be because of overdose or myxedema, hypothyroidism. Right. Very, very interesting, exciting is to look at the respiratory pattern in a comatose patient. Very interesting. In fact, if you have real clinical acumen and look at the respiratory pattern, you can even place the lesion. Neurology is a wonderful subspecialty because with history itself, we can place the lesion. In fact, there have been excellent clinicians who can even pinpoint the lesion. Here is an opportunity to place the lesion by looking at the respiratory pattern. Imagine there's a hematoma, big hematoma in the cortex going and compressing midbrain, pons, and medulla from rostrocaudal descent. By looking at the respiratory pattern, you can tell where the lesion is. For example, if it is in the cortex, it produces Cheyne-Stokes respiration. Waxing, waning, or waxing, waning. Then no respiration. Then no respiration. Waxing and waning pattern indicates Cheyne-Stokes respiration and indicates that the cortex is affected. And when the hematoma comes from the cortex to now midbrain, it produces a pattern of breathing known as central neurogenic hyperventilation. They just hyperventilate. And then when it comes to pons, it turns out to be an apneustic breathing. What is apneustic breathing? They take a deep inspiration, pause, and then slowly expire. Deep inspiration, pause, and then expire. So this kind of respiratory pattern, deep inspiration, pause, and expiration, deep inspiration, pause, and expiration is apneustic breathing. It is suggestive of pons, a lesion in the pons. And when medulla oblongata, the lesion comes to the medulla oblongata, the breathing becomes totally chaotic, irregularly irregular, as known as Biox breathing. We get an irregularly irregular pulse, that is atrial fibrillation, which can produce a cardioembolic stroke. Here we get an irregularly irregular breathing known as Biox breathing, suggestive of medulla oblongata lesion. So just by looking at the respiratory pattern, cortex, midbrain, pons, medulla, the descent, the change, the evolving pattern of the evolving respiratory pattern from Cheyne-Stokes to central neurogenic hyperventilation to apneustic breathing to Biox breathing, we can say where the lesion is. So this is what I've been telling: Cheyne-Stokes breathing, waxing, waning, central neurogenic hyperventilation, apneustic breathing, inspiration, pause, expiration, inspiration, pause, expiration. Irregular breathing is medulla oblongata, biotic breathing, totally irregularly irregular, chaotic breathing, and finally, it's the respiratory arrest. Temperature is important. If there's fever, it is suggestive of infection, inflammation, hypothalamic lesion, heat stroke, thyroid storm, or subarachnoid hemorrhage. If there is hypothermia, it could be sepsis, shock, myxedema, hypothyroid, coma, drug intoxications, barbiturates, or hypoglycemia. Another important point in hypoglycemia is that how do we make out clinically hypoglycemia? A person is diabetic, the chief has given the orders, give insulin so much units, and then he leaves. Night the resident does the rounds. He finds a person going into comatose state, a diabetic person who was perfectly well in the morning, took insulin, but in the night he slowly slips into an unconscious state. But what the resident has picked up is that he's got a lot of sweating. That should give you the idea. Sweating, if is there in a person who is comatose, always suspect hypoglycemia. Because when there is hypoglycemia, body always tries to maintain homeostasis. So when there is hypoglycemia, body tries to increase the blood sugar level by producing counter-regulatory hormones like steroids and catecholamines. So these not only increase the blood sugar level, but has got other side effects in the form of sweating. Fundus examination is very, very important. Increased intracranial pressure, there will be papilledema. Subarachnoid hemorrhage, it is subbiloid hemorrhage. Hypertensive encephalopathy, exudates, hemorrhages, AV nipping, papilledema. Diabetic retinopathy, new vascular formations, and new vessels. So these are the changes of fundus in hypertensive retinopathy and diabetic retinopathy. Head and neck. We have to go systematically examining a person who is in a comatose state. If there's scalp laceration, it could be trauma. Battle sign, if there is ecchymosis over the mastoid, you call that as battle sign. If there is ecchymosis around the eyes, it is known as the raccoon sign. Both of them suggest basilar skull fracture. If there's neck stiffness, it could be meningitis, subarachnoid hemorrhage, or cerebellar tonsillar herniation. Very important point, headache and neck stiffness. Any lesion in the brain, like putamen hemorrhage or a thalamic hemorrhage or infarct also, they usually do not produce headache. We have seen so many stroke patients having infarcts, but they do not produce headache. What is the reason? Because brain per se has got no pain receptors. Even if you cut the brain, there is no pain. It is only the coverings of the brain, the meninges and the vessels in the meninges, which are pain sensitive. And therefore, only when meninges or vessels in the meninges get affected, person develops headache. That's why we get severe headache in migraine, trigeminal vascular system, or subarachnoid hemorrhage, where the arachnoid membranes are affected, or meningitis. Meningitis affects the meninges. Subarachnoid hemorrhage, again, meninges are affected. Only if the meninges or the vessels in the meninges are affected, person develops headache. The brain per se does not produce headache. Hemorrhage sometimes produce headache. That is because of the raised intracranial pressure, again affecting the meninges. So brain per se does not produce pain. Even if we cut the brain, there's no pain. Very important point. So headache, neck stiffness, meningitis, subarachnoid hemorrhage. So these are all the important signs. You can see a raccoon sign, ecchymosis over the eyes, CSF rhinorrhea. How do you differentiate CSF rhinorrhea from the normal nasal secretions? Cerebrospinal fluid always obviously contains sugar. So when you take the fluid out and check out, if there is sugar, it is CSF rhinorrhea. If there's no sugar, it is only nasal secretions. CSF autouria. This is a battle sign. The D you can see there. Ecchymosis over the mastoid, hemotympanoid, and the bump over there. Right. If there is cyanosis, it could be hypoxia, cardiac disease, cyanide. If there's cherry reds, it could be carbon monoxide intoxication, jaundice, hepatic encephalopathy, or hemolysis, pallor, anemia, shock, hemorrhage. If there's petechia or purpuric rash, meningococcemia, sweating, that's what I said, hypoglycemia, counter-regulatory hormone, there will be sweating, erythema, you have to suspect polycythemia, alcohol, bruises, trauma, and coagulopathy. Heart, atrial fibrillation and carotid stenosis, hypertension are the most important modifiable risk factors for stroke. Atrial fibrillation, carotid artery stenosis, and hypertension are the most important modifiable risk factors for stroke. Like dyslipidemia is the most important modifiable risk factor for coronary artery disease. For stroke, it is hypertension, atrial fibrillation, and carotid artery stenosis. Therefore, we should always check out the heart. Arrhythmias, atrial fibrillation can cause cerebral embolism, murmur valvular heart disease, gastrointestinal tract hepatic encephalopathy or GI hemorrhage, genitourinary, urinary incontinence, seizures with postictal coma, hematuria, cerebral embolism, extremities. If there are subtle twitchings in a comatose patient, it could be a subclinical status epilepticus, non-convulsive status epilepticus. You should be careful. Again, very important, examination, clinical acumen. Just pick out all these small things. If you have picked up DU EEG and it shows the epileptic discharges, then it is non-convulsive status epilepticus. You have to give them anti-epileptic drugs. Posture. Decorticate rigidity and decerebrate rigidity. There's a tendency to get confused, but if you have your concepts clear, very interesting and fascinating is decorticate rigidity and decerebrate rigidity. Decorticate rigidity is arms flexed and legs extended. This is attributable to the intact rubrospinal pathways, which enhance flexor tone to the upper extremities and produce a flexed arm posture. Two important tracks you have to remember. The one which starts from the red nucleus goes down rubrospinal tract, which is concerned with the flexion of the upper limbs. Second is the vestibulospinal tract, which comes from the medulla oblongata, which is concerned with the extension. So when there's a lesion above the red nucleus, indirectly it implies that the red nucleus and rubrospinal tract are intact. So persons will flex the hands like this. Decorticate rigidity indicates that the lesion is above red nucleus, the rubrospinal tract is involved, and person has got flexion of the upper limbs. Prognosis is very good. But imagine if there's a lesion between the red nucleus and the vestibular nucleus. So the rubrospinal tract is cut off. So the rubrospinal tract no more functions effectively. So the flexion is lost. But vestibulospinal tract is intact. It causes extension. So persons will extend their hands and pronate, which is known as decerebrate rigidity. So the decorticate rigidity, the lesion is above red nucleus. Decerebrate rigidity, the lesion is between the red nucleus and vestibular nucleus. The decerebrate rigidity is because of the intact vestibulospinal tract, which produces extension posture. The decorticate rigidity is because the lesion is above red nucleus, implying that the rubrospinal tract is intact, produces the decorticate posture, flexion posture. So decorticate rigidity, arm flexed and leg extended, is attributable to the intact rubrospinal pathways, which enhance the flexor tone to the upper extremities, producing a flexed arm posture with an extended posture. Decerebrate rigidity in the extended posture of both arms and legs. The lesion between the red nucleus and vestibular nucleus, the rubrospinal tract ceases to function, but the vestibulospinal tract remains intact, facilitating extensor tone to all four extremities. So this is the diagram. This is the diagram. Yeah. Now coming to the examination, we tickle the nostril with the cotton whisk pressure or on the knuckles or bony prominences and pinprick stimulation. They are used to determine the threshold for arousal and the motor response on each side of the body. Very important in a comatose state person is to examine the brainstem reflexes. If it goes systematically, it is very easy. We need to check the midbrain, pons, and medulla oblongata, whether they are functioning or not. In midbrain, the function which we test is the pupillary reaction to light. In pons, we test two. One is the corneal reflex. Second is the spontaneous or the OCR, oculocephalic reflex. And medulla oblongata is concerned with the respiration. Right. Midbrain is concerned with the pupillary reaction. So when we throw light, if both the pupils constrict, direct and concentric light reflex is intact, midbrain is intact. So we check out on the pupillary reaction. If the pupils are constricting well to light, that means the pupils are reacting well, that means midbrain is intact. Pons we test by corneal reflex. We touch the wisp of cotton, the cornea, and both the eyelids close. If the corneal reflex is present, that means pons is intact, because the cornea touch, ophthalmic division of the trigeminal nerve, the efferent is bilateral seventh nerve, orbicularis oculi. Very important clinical point. Nature has been so kind to us. It wants the eye to be protected at any cost. Therefore, will you believe that there are no receptors on the cornea? There are only pain receptors, free nerve endings, because God and nature wants to protect our eye at any cost. So when you touch the cornea, you're not stimulating the touch receptors. In fact, there are no touch receptors. You're stimulating the pain receptors, free nerve endings, and then it immediately person becomes alert and closes eye. That's the corneal reflex. Oculocephalic reflexes. When we turn the head to one side, the eyes go to the opposite side. The labyrinthine is connected to the PPRF on the opposite side, and therefore when we turn the head to one side, the PPRF is stimulated, the eyes goes to the opposite side. This is known as oculocephalic reflex. And finally, medulla oblongata is concerned with respiration. So we check on all these things. Pupillary light reaction, midbrain is intact. Corneal reflex, OCR is intact. Pons is intact. Respiration, medulla oblongata is intact. So these are the reflexes we check. Brainstem reflexes. Patients with preserved brainstem reflexes typically have a bihemispheric location to coma, including toxic or drug intoxication. So brainstem reflexes are intact. It should be obviously cortical involvement. Bicortical, I repeat, not the one cortex, both the cortices. Or a patient with abnormal brainstem reflexes either have an RAS localization to their coma or suffering from the herniation coming and impacting the brainstem from a cerebral mass lesion. Right. Now we check out on the pupils, very, very important. The pupillary size is normally 2.5 to 5 millimeters. If there are pupillary dilatation more than 6 millimeters, that means the compression of the third nerve is affected. There's a severe brain damage or anticholinergic drugs. Very important clinical point. The third nerve causes 4D. If third nerve gets affected, dilatation of the pupil, drooping of the eyelid, a divergent squint, and because of that, double vision. The pupillary dilatation is because of the parasympathetic fibers running superficially on the third nerve. So if there's any lesion like hematoma or aneurysm coming and compressing the third nerve, it is the parasympathetic fibers which get first affected, and therefore the pupils first get affected. That's why in head injury, you have to always check out on the pupillary size. Because of the hematoma, it goes and compresses the superficially placed parasympathetic fibers. The parasympathetic fibers are the first to get affected, so there'll be asymmetry of the pupil. On the other hand, like diabetes, if it's an intrinsic pathology of the third nerve, where the center of the third nerve gets affected, there's a blood loss to the third nerve, but the superficially placed parasympathetic fibers don't get affected. Even in case they get affected, they are the last to get affected. So pupillary sparing third nerve palsy is an intrinsic pathology of the third nerve, like diabetic third nerve palsy. A person having a pupillary involvement first is an extrinsic pathology of the third nerve, like PCOM aneurysm, posterior communicating artery aneurysm, or an hematoma. If there is small pupils, we have to suspect pontine hemorrhage. Pons is supplied by a single basilar artery. So when the pons ruptures, it goes diffusely and affects both the sympathetic pathways. So when the sympathetic pathways gets affected, they are responsible for dilatation of the pupils. So when they get affected, pupils are small. So pontine hemorrhage, that's the reason why the pons are small, why the pupils are small in pontine hemorrhage. So small pupils, hydrocephalus, thalamic hemorrhage, Horner's syndrome. Yeah. Very interesting. 2 points, 2 clinical points where the students tend to get confused. First is the maxim. Eyes look towards the hemispheric lesion and away from a brainstem lesion. I've seen a lot of students not understanding this concept and somehow trying to mug it. If you understand this concept, it is really fascinating. For this to understand, you need to understand this diagram which is being displayed. You see the frontal cortex eye fields area number 8, and then the labyrinthine apparatus here. Both go and connect to the PPRF on the opposite side. The frontal cortex and the labyrinthine apparatus, 8th nerve, go and connect to the PPRF on the opposite side. Whereas frontal eye fields pushes the eyes to the opposite side in a fast manner, whereas labyrinthine apparatus pushes the eyes in a slow manner. That's the only difference. But both the frontal cortex and the labyrinthine apparatus go and connect to the PPRF on the opposite side. What does the PPRF do? It connects the 6th nerve on the same side and through MLF, the 3rd nerve or medial rectus on the opposite side. So PPRF will pull eyes towards each side. Very fascinating. So in the frontal eye fields area number 8 is stimulated, or the labyrinthine apparatus is stimulated, the eyes will go to the opposite side because the PPRF on the opposite side gets stimulated. So in the frontal, that's why when the frontal eye fields is stimulated, eyes goes to the opposite side. That is known as saccadic pathway. The PPRF goes to PPRF and connects. The vestibular apparatus, if it is stimulated also, eyes will go to the opposite side because it goes and connects to the PPRF on the opposite side. How do you stimulate the vestibular apparatus? Either by turning the head to the opposite side, you stimulate the vestibular apparatus, or by pouring warm water. By pouring warm water or turning the head to the opposite side, you are stimulating the vestibular apparatus. The moment vestibular apparatus is stimulated, what happens? It goes and stimulates the PPRF on the opposite side, so eyes will be pushed to the opposite side. That is the oculocephalic reflex. That is the dog's eye movement. When we turn the head to one side, the eyes go to the opposite side. Why? When we turn the head to the one side, the vestibular apparatus gets stimulated, it goes and connects to the PPRF on the opposite side, eyes go to the opposite side. This is a wonderful explanation. Likewise, when you pour warm water, Again, the vestibular apparatus gets stimulated, eye will go to the opposite side. So frontal eye fields and the labyrinthine apparatus both push the eyes to the opposite side. So what happens now? Imagine when we put warm water. When we put warm water, we stimulate the vestibular apparatus, eyes goes to the opposite side. But body always tries to maintain homeostasis. Oh, it has realized the eyes has come to the opposite side. I should put it back to its normal position. So it tries to push it to the normal, that is to the medial part. How does this happen? Frontal eye fields area number 8 will try to put it back. So when you put warm water, eyes will go to the opposite side because you're stimulating vestibular apparatus. Frontal eye fields area number 8 will try to push it back towards its normal position. So there will be nystagmus. So when you put warm water, the nystagmus is towards the same side. When you put cold water, you are inhibiting the vestibular apparatus. So this vestibular apparatus now will get stimulated. Eyes will go towards this side. But frontal eye field area number 8 will try to put it back to its normal position, so there will be nystagmus. So when you put cold water, the nystagmus is towards the opposite side. When you put warm water, the nystagmus is towards the same side. What beautiful explanation. This is known as mnemonic cause, cold opposite, warm same. So when there's a frontal eye fields area number 8 lesion, it cannot push the eyes towards the opposite side. The saccadic pathway is affected. So eyes will move toward the same side, and hemiplegia will be on the opposite side. So eyes look to one side and hemiplegia is on the opposite side. Whereas if the pons is affected, the PPRF is affected, it cannot pull the eyes towards its side. So eyes will go to the opposite side and hemiplegia is also on the opposite side. So eyes will look towards the side of hemiplegia and a pontine lesion. Eyes will look to one side and hemiplegia on the opposite side is a frontal lobe lesion. So this is the wonderful explanation. You can see the frontal eye fields going and connected to the PPRF, vestibular apparatus connecting to PPRF, and therefore, and you see the corticospinal tract coming like this. So if the frontal eye fields area number 8 is affected, it cannot push the eyes towards the opposite side. Eyes will move to the same side, but hemiplegia is on the opposite side. Spontaneous movements. Spontaneous movements, you don't even touch the patient, you just see the eye movements. Ocular bobbing, if there's a brisk downward movement and slow upward movement of the eyes associated with the loss of horizontal eye movements, it indicates bilateral pontine damage. Ocular dipping, slow downward movement followed by a fast upward movement in patients with normal reflex eye movement suggestive of diffuse cortical damage. Right. Herniation. Herniation refers to the displacement of the brain tissue by an overlying or adjacent mass into a compartment, contiguous compartment that it normally does not occupy. So that is herniation, is a brain tissue coming from one compartment to the adjacent compartment through an orifice. So how do we find out the rostrocaudal herniation? I've already discussed this, just a rapid review. If there is cerebral cortex, there will be Cheyne-Stokes respiration, there will be decorticate rigidity, flexion of the upper limb, extension of the lower limb. If the midbrain is involved, there is central neurogenic hyperventilation and decerebrate rigidity because the lesion is between the red nucleus and vestibular nucleus. If there is pons, there is apneustic breathing. If there is medulla oblongata, there is bios breathing. So by correlating the breathing pattern and the posture, we can even place the lesion. These are the various herniations. Yeah. Coma due to metabolic causes. So far, I've been discussing structural causes. Metabolic causes. Many systemic abnormalities cause coma by interrupting the delivery of energy substrates, oxygen, glucose, sodium, or by altering the neuronal excitability like epilepsy, anesthesia, drugs, and alcohol. In metabolic encephalopathy, clouded consciousness and coma are in a continuum. It's a slow process, metabolic. Hypoglycemia, slowly they develop. Hyponatremia, slowly they develop. But structural causes, hemorrhage, suddenly they develop deficit and suddenly they become comatose. Very important point. That's why history is very, very important, of paramount importance. The temporal profile of the illness we need to ask. Yeah. So structural cause, any person comes in a comatose state, we always need to remember how we approach. The best clinical approach to coma is find out whether it's a structural cause of coma or metabolic cause of coma. If it is structural cause of coma, there will be focal signs, pupillary dilatation on one side, hemiplegia on one side. So focal signs. Whereas metabolic disorders like hypoglycemia, this is a generalized disorder. And structural cause like pontine hemorrhage, pupils are usually affected, or PCOM aneurysm, pupils are affected, whereas pupils are usually not affected in metabolic encephalopathy, exceptions like drug overdose like opiates. But by and large, metabolic encephalopathy, pupils are normal. Asterixis is not present in structural cause of coma, but in a metabolic cause of coma, a drowsy and confused patient, but still a person who is able to understand the commands and listen. Bilateral asterixis is a definitive sign of metabolic encephalopathy or drug intoxication. Obviously, if it's a structural cause, CT or MRI is going to be abnormal, whereas in a metabolic cause, hypoglycemia or hyponatremia, CT and MRI is going to be normal. Blood investigations are usually going to be normal in a structural cause, whereas blood investigations like glucose or sodium are going to be decreased in a metabolic disorder. So very important 5 points to differentiate between a structural cause of coma or a metabolic cause of coma. So lab studies, we do a chemical and toxicological analysis of blood and urine like hypoglycemia, hyponatremia, ABG analysis for lung disorders, CT and MRI for structural disorders like extradural hematoma, subdural hematoma, or stroke. We do EEG, very important. As I was mentioning in the exam, the subtle twitchings. Person is comatose, always suspect non-convulsive seizures. Non-convulsive status epilepticus. So we should always take EEG to pick up the epileptiform discharges. EEG can also be useful in Creutzfeldt-Jakob disease and herpes simplex viral encephalitis. In herpes simplex viral encephalitis, it goes to the nose and therefore the temporal lobes get affected. So if we see CT scan or MRI hyperintense signal or CT scan hypodensity or EEG sharp waves in the temporal lobe, we should suspect herpes simplex viral encephalitis. Creutzfeldt-Jakob disease is a prion disease wherein you get periodic waves, 1 per second, then another wave, another wave. Periodically it comes in a regular fashion. That is Creutzfeldt-Jakob disease. Triphasic waves, if you have a vector with 3 directions, the triphasic wave suggestive of hepatic encephalopathy. Benzodiazepine overdose, widespread beta activity. There's benzodiazepine overdose, we have widespread beta activity. We have alpha, beta, theta, and delta. We have widespread beta activity, you have to suspect a benzodiazepine overdose. CSF analysis, if it is meningitis or encephalitis, there's going to be inflammatory disorder. So obviously the cells are going to increase, the proteins are going to increase, the sugar is going to come down. If that's the kind of picture we get, we have to suspect meningoencephalitis. So these are the 5 basic tests we need to do in a person who is in a comatose state. Right. This is very important slide. There are so many causes of coma, and we cannot remember all the causes of coma, and it's not worth remembering all the causes of coma without understanding the mechanism of coma. So if you know these 3 broad categories, one, you have understood the full concepts of coma. Second, almost any cause of coma, you can place them in one of these 3 categories. What are these 3 categories? One, coma without focal neurological signs. There are no signs at all. Person is in comatose state. So what will you suspect? Metabolic, toxic encephalopathies. So there are no neuro, for example, hyponatremia, no neurological disease. Person goes into a comatose state. Coma with prominent focal signs like stroke and PCOM aneurysm or going in a fainting or pontine hemorrhage, pupillary abnormality will be there. So they'll be having prominent focal signs, cerebral hemorrhage. Coma with meningitis syndrome, fever, neck stiffness. I said headache, neck stiffness, meninges get inward, suspect subarachnoid hemorrhage or infectious pathology like meningoencephalitis. So almost any cause of coma can be put in one of these categories. Coma without focal neurologic signs like metabolic encephalopathy like hypoglycemia or hyponatremia. Coma with prominent focal signs like stroke, cerebral hemorrhage, cerebral infarct. Coma with meningitis syndrome like meningoencephalitis or subarachnoid hemorrhage. So this is a broad approach. This is the way we approach a comatose patient. Instead of running through all the causes, we try to put it in one of these categories and then analyze. Right. Now comes the question. Different types of strokes itself can cause coma. So how do we differentiate? Different types of stroke itself can cause coma. So how do we differentiate these different causes of coma? One, the basal ganglia thalamic hemorrhage, hemiparesis, eyes looking down and small pupils. Very important clinical point. In thalamic hemorrhage, eyes are looking down and eyes are small. What is the mechanism? The eyes are looking down because we need to understand one important concept here. We have horizontal eye movements, we have vertical eye movements. The center for all horizontal eye movements is pons. be it saccadic pathway, the fast movement, or pursuit movement, the slow following movement. For example, someone knocks at the door, I want to quickly see, that is known as saccadic movement. That is also a horizontal movement. But I see a nice shuttlecock match going between Indian superstar Sindhu and some other player. So I keep following the shuttlecock like this. These are known as pursuit movements. So horizontal eye movements are basically two types: saccadic, the fast movement; pursuit movement, slow movements. So the horizontal eye movement, the center is in the pons. Likewise, we have vertical eye movements, up gaze, down gaze. The center is in the midbrain. So vertical eye movement, the center is in the midbrain. Horizontal eye movement, the center is in the pons. Vertical eye movements, again, there are two types: up gaze and down gaze. Up gaze fibers cross and then descend, whereas down gaze fibers descend straight away. Up gaze fibers cross and then descend, whereas down gaze fibers descend straight away. So if there's any lesion going and impinging on the top of the midbrain, it affects the crossing up gaze fibers, but not the down gaze fibers. So anything which goes and impinges on the top of the midbrain, like Parinot syndrome or thalamic hemorrhage, because thalamus is so close to the top of the midbrain, or hydrocephalus. So it goes and impinges the top of the midbrain, affects the crossing up gaze fibers, so they cannot look upwards, they'll be looking down. So on a sunset sign, in hydrocephalus, we say it's a sunset sign. Why? It goes and impinges at the top of the midbrain where the crossing up gaze fibers are affected, so they cannot look upwards, they'll be looking downwards. So that's the explanation, fantastic explanation. Thalamic hemorrhage, why eyes are looking downwards is because it's going and impinging the top of the midbrain, because thalamus is just above the midbrain. Second, why the eyes are small in thalamic lesion? Obviously, the sympathetic tract, hypothalamus, it comes from the hypothalamus, close to thalamus. So when the sympathetic gets affected, the dilatation gets affected, the pupils are small. When it comes to these eye movements, horizontal eye movements and vertical eye movements, one important syndrome I need to talk is the locked-in syndrome. Very interesting and exciting. Locked-in syndrome is an infarct in the pons. So when there's an infarct in the pons, the horizontal eye movements are affected. Because there's an infarct in the pons, the corticobulbar corticospinal fibers are affected. So when there's an infarct in the pons, person cannot move eyes horizontally, person cannot use upper limbs and the lower limbs, but midbrain is intact. So he may be able to move the up, he will be able to use eyes vertically, up and down movement is possible. So locked-in syndrome, all horizontal eye movements are affected. Person cannot use upper limbs, person cannot use lower limbs, but up and down movements are intact. That is locked-in syndrome. Very interesting. So locked-in syndrome, pons is affected, horizontal eye movements are affected, corticobulbar corticospinal fibers are affected, upper limbs, lower limbs are affected, but since midbrain is intact, the vertical eye movements are spared. Cerebellar hemorrhage, it also produces nystagmus, but two important points. One, cerebellum inhibits the vestibulo-VOR, vestibulo-ocular reflex, so the findings are just the opposite of vestibular stimulation. One. Second, the nystagmus between the cerebellar or the central cause and the peripheral cause of nystagmus is very important. In the central cause of nystagmus, it will be direction changing nystagmus. It comes to one side, beats, comes to again normal, goes to the other side, changes the direction. Direction changing nystagmus comes one side, beats this side, comes to the center, goes to the side, beats on the opposite side. Direction changing nystagmus, think of central cause, cerebellar hemorrhage, periodic alternating nystagmus, Brown's nystagmus. Whereas if it's a vestibular nystagmus, when the vestibulum is stimulated, eyes will go to one side because PPRF is stimulated, frontal eye fields will cause nystagmus to one side. So it's unidirectional, cold, opposite, warm, same cause. So it's unidirectional either to this side or that side. Cold, opposite side, warm, same side. Unidirectional is the peripheral nystagmus, whereas cerebral hemorrhage, it could be a bidirectional or direction changing nystagmus. Very important. Basilar artery thrombosis, because the pons is affected, the important 3, 4, 6 cranial nerves gets affected and have diplopia, dysarthria. Subarachnoid hemorrhage, as I said, meninges are highly sensitive to pain. So sudden severe headache, always suspect subarachnoid hemorrhage. Infections, meningitis, encephalitis, they produce headache. Sudden severe headache, meningitis, subarachnoid hemorrhage. MCA, though it is the most common cause of stroke, it may not cause coma unless there is massive cerebral edema. I've been repeating this right from my first slide. One side cortex, person does not lose consciousness because RAS goes to both the cortices. So unless both the cortices get affected, person does not lose consciousness. So an MCA stroke per se does not cause coma, but it can cause coma if there's a massive cerebral edema going and pushing the other cortex, or the massive edema causing midline shift. Only then it produces coma, otherwise it does not produce coma. Right. So what is the treatment for coma? If there is hypoglycemia, one of the important treatable causes, we always give IV dextrose. But persons alcoholism with hypoglycemia, as I said, there will be thiamine deficiency, will be precipitating Wernicke's encephalopathy, and therefore we should give first thiamine and then glucose to avoid provoking Wernicke's encephalopathy. If there is narcotic overdose, we give naloxone. If there is stroke CVA, we give thrombolysis or mechanical embolectomy. If there is diazepam overdose, we give flumazenil. If there is ethylene glycol, we give fomepizole. But then we are not sure. Person is come in a comatose state, very serious, deteriorating. What can we do? Then we can go for coma cocktail. It consists of dextrose, flumazenil, naloxone, and thiamine is sometimes used in the initial management of comatose patients known as coma cocktail. So we give all these four: dextrose, flumazenil, dextrose for hypoglycemia, flumazenil for diazepam overdose, naloxone for opioid, and thiamine for alcoholism. So we give all these four together known as coma cocktail. Metabolic comas have got far better prognosis than traumatic ones. Hypoglycemia, you give dextrose, they recover. Hyponatremia, you give saline, they recover. But structural causes, they do not have good prognosis as compared to metabolic cause of coma. The absence of cortical responses of somatosensory potentials has been shown to be a strong predictor of poor outcome following hypoxic injury. Coma, how do we stage the person, especially head injuries? We use a scale known as Glasgow Coma scale, is used in the evaluation of patients with impaired consciousness, particularly head injury. Eye opening, best verbal response, best motor response, we give a scale. The maximum is 15 points, the least is 3 points, not 0, because even if there's no response, we give 1 point each. So opens spontaneously 4 points, opens only to verbal stimuli 3 points, opens only to pain 2 points, never opens 1 point. Best verbal response oriented in converse is 5 points, disoriented confused 4 points, inappropriate words 3 points, incomprehensible sounds 2 points, no verbal sounds 1 point. Best motor response, obeys command 6 points, localizes pain 5 points, withdraws to pain 4 points, decorticate rigidity 3 points, decerebrate rigidity 2 points, no motor response 1 point. As I said, highest GCS 15 by 15, but lowest GCS is not 0, 3 by 15. Yeah. Brain death. This is a state of irreversible cessation of all cerebral and brainstem functions with preservation of cardiac activity and maintenance of respiratory and somatic function by artificial means. So what is the fundamental difference between brain death and the normal death? Normal death, a person who is dead, nothing is working. Whereas in brain death, only one thing is still working, that is the circulation. Then you may ask the question, if the person is not breathing, then he's going to eventually die. Then how do you say he's not going to die? Yes, eventually he's going to die. So you have to immediately connect him to the ventilator. In a brain dead person, only circulation is going on. The respiration is also absent, cessation of respiration. You maintain respiration by artificial means like ventilator. So the only difference between brain death and the normal death is the normal death and cessation of all functions, whereas brain death, the only function is still going on in circulation. There is cessation of respiration. You have to maintain respiration by artificial means. And why is this state very important? Why neurologists are called upon? Why people certify brain death in the ICU? Two reasons. One, it is irreversible. There's no point in continuing with your supportive measures because it's irreversible. It's not going to come back to life. Second, for organ donation, transplantation. This is the perfect state wherein we can take organs for transplantation. In a person who is dead, totally dead, the circulation is absent, so organs have also died. So you cannot take organs because they are non-functioning. In a person who is completely alive, you cannot take organs because he may say he may not interested in giving the organs, and he may sue us also because you're depriving him of his normal privilege of having organs. So you cannot take organs from a person who is alive completely unless he gives consent. And you cannot take organs from a dead person because the organs are in function because circulation is affected. So here is a state where a person cannot come back to life. It's an irreversible state, but organs are still functioning because circulation is going on. So perfect state to take organs. That's why brain death is so very important. Brain death is an irreversible state, and that life support is useless, and brain death is principal requisite for the donation of organs and transplantation. In adults, traumatic injury and subarachnoid hemorrhage are the chief causes of death, whereas in child abuse, accidents and asphyxia are common causes of death. The criteria for brain death contain two essential elements after other confounding factors like hypothermia and drug intoxication are ruled out. Why should we always rule out hypothermia and drug intoxication? Because they depress the reflexes. So when there's hypothermia and they depress the brain reflexes, you may think the person is brain dead. That's not the case. It is because of hypothermia, the brain stem reflexes have been temporarily diminished. So always we have to rule out hypothermia and drug intoxication. Even drugs can depress the brainstem reflexes. So we have to always rule out hypothermia and drug intoxication. What are the two components? One, the cortex, second is the brainstem. Both should get affected. Widespread cortical destruction that is reflected by deep coma and unresponsiveness to all forms of stimulation. Global brainstem damage, that is midbrain gone, pons gone, medulla oblongata is gone. Midbrain is gone because of pupillary reaction is absent. Pons is gone because corneal reflex is absent. OCR is absent. Medulla oblongata is gone because cessation of respiration. We maintain by artificial means like ventilation. So global brainstem demonstration by absent pupillary light reflex, absent corneal reflexes, loss of oculovestibular reflexes, and destruction of the medulla manifested by complete and reversal apnea. So these are the reflexes which I've explained in comatose state: midbrain, pons, medulla, midbrain pupillary light reflex, pons corneal reflex, and OCR, medulla oblongata respiration. So OCR we check out. When we check the OCR, two important points can be gained. One, when we put warm water, it stimulates and the eyes go to the opposite side, frontal eye fields pushes this to the same side. When we put cold water, we are inhibiting the vestibular apparatus. So this vestibular apparatus will push the eyes to this side and frontal eye fields will try to cover by having nystagmus. So cold opposite warms in. So when we put cold water, the nystagmus is always opposite side. So there are two components. One is the slow movement. Second is the corrective nystagmus. So the slow movement is affected. That means the brainstem is affected. If the slow movement is affected, the connection between the vestibular apparatus and the PPRF is affected, the brainstem pathway is affected. If the slow movement is affected, the brainstem pathway is affected. So when you put cold water, the eyes will move to the same side because you are inhibiting the vestibular apparatus. This vestibular apparatus will stimulate and the eyes will move to the same side. But frontal eye fields, area number 8, will try to put it back to normal side. There will be nystagmus. So if the slow eye movement is affected, brainstem is affected. If frontal eye fields, area number 8 is affected, the corrective nystagmus is affected. So if slow movement is affected, brainstem is affected. If the corrective nystagmus is affected, frontal lobe is affected. It could be hypoxemic encephalopathy, it could be metabolic encephalopathy, it could be whatever may be the reason. One point. The slow movement is affected, the brainstem is affected. If the corrective nystagmus is not there, that means frontal fields are affected. The second point, the oculocephalic is normal. So in a comatose patient, when we turn the head to one side, we are stimulating the vestibular apparatus. So PPRF on the opposite side is stimulated. So eyes move to the opposite. In fact, it's known as doll's eye movement. When we are children, we are playing with dolls. When we move head to one side, eyes go to the opposite side. So when we turn the head to one side, eyes should go to the opposite. In a comatose patient, it's a normal response. It should be present. When we turn in a comatose patient head to one side, eyes should go to the opposite side. It's a normal response. It has to be present. Only if it is not present, either you suspect the brainstem pathology or the corrective nystagmus affected the frontal lobe pathology. Then the question comes, as a person, as a conscious person, when I turn my head, I can look to the right, I can look to the left. How is it possible? We said that when we turn the head to one side, eyes will go to the opposite side. But here I am turning my head to one side, looking to the right side or looking to the opposite side. How is it possible? As a conscious patient, as a person who has got consciousness, my frontal lobe can inhibit this reflex. So in a conscious person, the frontal lobes are intact, they can inhibit the reflex. Only when the consciousness is slowly coming down, this reflex slowly becomes manifest. So in a comatose patient, OCR doll's eye movement is normal. But in a conscious patient, it is up to me to look wherever I want. My frontal lobe is intact. But in an unconscious patient, as the functioning level comes down, this reflex becomes manifest. Very important point. So how do we confirm it? We check for the absence of brainstem reflexes. We do a test known as apnea testing, wherein by even increasing PaCO2 to 60 millimeters of mercury, person's respiratory centers are not stimulated and is not going to initiate respiration. That means medulla is affected, known as apnea test. Yeah. Then we do some confirmatory tests. We do EEG. When we do electroencephalogram, it will be isoelectric. We don't have that alpha, beta, theta, and delta coming up. When we do cerebral angiography, when we give contrast medium injected under high pressure in both anterior posterior circulation, no intracerebral filling should be detected at the level of entry of the vertebral arteries of this color. When you do cerebral angiography, no intracranial filling because it isn't functioning. The transcranial Doppler measurements, no flow. Radionuclide brain scanning, again a dynamic nuclear brain scan showing no intracranial filling, known as hollow skull sign. Yeah. What happens is that, very interesting, sometimes residents declare brain death correctly, but then suddenly person does this kind of movement and the patient's attendance comes and start fighting the resident and then the chief has to come for the rescue. Can these movements happen even a person who is brain dead? It can happen, known as Lazarus sign or Lazarus reflex. These are the reflexes originating from the spinal cord, not from the brain. And therefore, even if a person is brain dead, since the spinal cord is intact, these reflexes can happen. So we have to be careful, counsel and explain the person's attendance. So occasionally, other reflexes that originate from the spine may be present and should not preclude a diagnosis of brain death. The Lazarus sign or Lazarus reflex is a reflex movement in brain death patient, which cause them to briefly raise their arms and drop across their chest. A Lazarus reflex is a reflex mediated by the spinal column and not through the brain. Therefore, this movement is still possible in brain dead patients. Very important point. We have to be confirmed. We have to show our authority in saying these findings to the patient's attendance. Otherwise, we may get into problem. Yeah. Locked in some syndromes which may mimic brain death, and we need to be careful. Locked in syndrome, as I said, if there's an embolus in the basilar artery and pons gets affected, horizontal movements are affected, person is quadriplegic, the only movement possible is vertical eye movements. So we may confuse with the brain death. Guillain-Barré syndrome, all the limbs are paralyzed, again we may get confused. Hypothermia, the brainstem reflexes disappear when the core temperature drops below 28 degrees centigrade. That's the reason. Drug intoxication, again, we need to check because it can also affect the brainstem reflexes. Note, when ingested in large quantities, many drugs can cause a partial loss of brainstem reflexes. Drugs and hypothermia can inhibit the brainstem reflexes, and therefore they should not be mistaken for brain death. So these are the confirmatory tests: coma, absence of motor responses, pupillary responses, corneal, caloric, gag, coughing, sucking, and absence of respiratory drive at a PaCO2 that is 60 millimeters or 20 millimeters above normal baseline lines, which is known as apnea test. When we confirm, we sometimes use we test twice, especially in children, because the findings are not obvious, and we use confirmatory tests. Confirmatory tests, especially in children and infants, in intervals between two valuations according to the patient's age. Term to 2 months, 48 hours, more than 2 months to 1 year old, 24 hours, 1 year to less than 18 years, 12 hours, more than 18 years, interval optional. Confirmatory test, term to 2 months old, 2 confirmatory tests, because the findings are not obvious in infants. 2 months to 1 year, 1 year old, 1 confirmatory test, 1 year old to less than 18 years, optional, more than 18 years, again optional. Why we use confirmatory tests, and why do we need to examine a person 2 times with an interval of time? Because of the limitations on the clinical examination of the neonates, especially an observation period of 48 hours is required and a confirmatory test. Yeah, I'm very passionate about teaching. I have my own educational YouTube channel, Dr. Sreenivas Medical Concepts, Dr. Dr. Sreenivas, SRENIVAS, Medical MEDICAL, Concepts, CONCEPTS. I have nearly 5,000 plus subscribers. I have almost all topics of neurology I have uploaded, but I continue because I'm always a student. Neurology is an ever learning process. So more than 200 neurology videos have been uploaded, but I keep uploading neurology at least once a week. So if you have any doubts or suggestions, you can look at my videos. You can post your comments, suggestions. I'll be more than happy to respond to your comments. So this is my channel, my education YouTube channel, Dr. Sreenivas Medical Concepts. And yeah, I'm the author of the book Focussed Neurology. as I was introduced with kind words by a resident doctor, I put almost all the topics of neurology in a question answer format. It is available online, especially Amazon. You can book it within a week. You will get the book Focussed Neurology by Sreenivas. Once again, I have to thank from the bottom of my heart for the White Army for giving me such an excellent opportunity to address the allied gathering across the country. What an opportunity, and what a wonderful gesture, the White Army, and especially your tagline, help others to help ourselves. Wonderful tagline. I also believe that, in fact, by teaching, you're learning yourself. In fact, to teach you all, I've really spent a lot of time trying to understand the concept. So I'm also learning by teaching you. So I thank once again for the wonderful opportunity, the White Army. Thank you. Over to the administration and organization. Thank you. Yeah.
Thank you, sir.
Yeah. I think I have finished it in time, 1.5 hours, 7 to 8:30. I find about 4 questions in the chat box. Yeah, now I think it's going to 5. Should I look at this chat box and answer the questions, or is it the administration going to?
No. No. No.
Yeah, please.
No.
Yeah. Should I open the chat box, or the administration is going to, the moderator is going to come in? Yeah, Dr. Vijay is there, I think.
Thank you so much for that wonderful class, sir. I think it's very useful for both undergraduate, as very useful for especially postgraduates, because we'll be seeing patients day in and day out. I think it's very useful for all of us.
Yeah, is it Dr. Vijay?
Yes, sir. Vijay here, sir.
Yeah, I find some 8 questions in the chat box. Are you going to?
Yes, sir.
Read out the questions for me, or should I open and then answer?
Yes, sir. I'll be reading it, sir.
Yeah, sure.
One question was, why single hypoglycemia causes coma, but large MCA infarct doesn't cause coma?
Yeah, very good question. In fact, one of my favorite topics. As I said, the reticular activating system comes in the brainstem and goes to both the cortices. So both the cortices should get affected for a person to lose coma. If only one cortex gets affected, person does not lose consciousness. In an MCA infarct, for example, left MCA infarct, it affects only one cortex. So person does not lose consciousness. Whereas if it is hypoglycemia, it causes a metabolic impairment of the entire RAA system. So person loses consciousness. Because of the diffuse involvement in the metabolic encephalopathy, person loses consciousness. Whereas in a structural causes, both the cortices should get affected, not just one cortex, because it becomes focal and person does not lose consciousness. That's it, Vijay.
Yes, thank you, sir. There is one more question. Why in thalamic hemorrhage the pupils are small and the eyes are looking down?
Yeah. Very interesting question. As I said, horizontal eye movements, the center is in the pons. Vertical eye center, the center is in the midbrain. Again, the vertical eye movements, there are two types. One is the up gaze looking up. The other is down gaze looking down. The up gaze fibers cross in the rostral part of the midbrain, the upper part of the midbrain, and then descend, whereas the lower, where the down gaze fibers descend straight away. So any lesion near the top of the midbrain, like thalamus, or a tumor like pineal gland tumor, Perrinot syndrome, or hydrocephalus, will go and impinge on the top of the midbrain where the up gaze fibers are crossing. So up gaze fibers get affected, so they can't look upwards, they'll be only looking downwards. Example, hydrocephalus, we call that a sunset sign. Same thing applies to thalamic hemorrhage, same thing applies to Perrinot syndrome. The crossing up gaze fibers get affected, so they'll be only looking downwards. They can't look up because up gaze fibers are affected. Why the pupils are small? Because the sympathetic pathway arises from the hypothalamus, just underneath the thalamus. So when they get affected, the sympathetic pathway gets affected. Sympathetic pathway is responsible for dilatation of the pupil. So when it gets affected, there'll be small pupil. So small pupil, eyes looking downwards, always suspect thalamic hemorrhage. In fact, eye signs in stroke is very fascinating. In fact, there have been wonderful clinicians, by looking at just at the eye movement and eye, they can tell the lesion. Oh, the question seems to be increasing now from 4 to 5 to 6 to 12. Great. That means people have really listened well, and then they're trying to clarify their doubts.
Yes, sir, definitely. One more question is, should we do calorie test in all comatose patients?
Dr. Vijay, I didn't get it. What?
Should we do calorie test in all comatose patients?
Should you do a caloric test in all patients? For example, you take CT scan and it shows obvious frontal lobe infarct, MCA infarct, or a thalamic hemorrhage, you need not. But when you're suspecting a brainstem pathology and the imaging is not yet done, you have to test the caloric testing, OCR, cold opposite warm same. It gives a lot of information. One of very useful tests is caloric testing. But now with the advent of imaging, we get scanning done in almost all the centers, especially CTs available, and they go ahead. Especially brainstem, the CT may not pick up, MRI picks up, and many centers may not have MRI. In such situations where you need to focus on brainstem, you have to do OCR, oculocephalic reflex, doll's eye movement.
So there's one more question, continuation of that. They've asked if we could mention what is the temperature that has to be used when we are calorie test.
Yeah, it's given in books. We just say warm water and +7 or -7 to normal degrees. It's standard.
Yes, sir.
Test tubes. Yeah.
One more question. Now they've asked is what is the reason why in frontal lobe lesions eye is divided to the same side, whereas in while hemiplegia is on the opposite side?
Yeah, this is actually a maxim. Eyes look to one side and hemiplegia is on the opposite side in a frontal lobe lesion, whereas eyes look towards the same side as that of a hemiplegia in a pontine lesion. So to explain that, we need to know this saccadic pathway. The frontal eye fields, from frontal eye fields area number 8, the saccadic pathway descends, crosses over to the opposite side, goes to the PPRF. The PPRF is paramedian pontine reticular formation. It connects the 6 nerve lateral rectors on the same side and medial rectors through MLF on the opposite side. So in the frontal eye fields area number 8 is stimulated, eyes will move towards the opposite side. That's why in an irritative seizure, versive seizure, when there's a seizure locus in the frontal lobe, eyes will turn to the opposite side like this. When you see eyes turning to the opposite side, you know that the origin of the seizure is in the frontal lobe. So when the frontal lobe is stimulated, eyes goes to the opposite side. Good. But what happens at the other end of the spectrum? When the frontal lobe is not functioning, eyes cannot move to the opposite side. So eyes will move to the same side. But the corticospinal tract originates from the frontal lobe, comes to the internal capsule midbrain pons medulla. At the level of the medulla oblongata, it goes to the opposite side. So if there's a frontal lobe lesion on one side, eyes will be looking to the same side, but hemiplegia is on the opposite side because corticospinal tract crosses at the level of the medulla oblongata and goes to the opposite side. So eyes looking to one side, hemiplegia on the opposite side is the frontal lobe pathology. Suppose we'll take a pons. PPR, a paramedian pontine reticular formation. What is the action of the PPRF? It pulls the eyes towards its side by connecting lateral rectus 6th nerve and medial rectus through MLF, the opposite side. So PPRF pulls the eyes towards its side. So when the PPRF gets affected, it cannot pull the eyes towards the same side, its side. Eyes goes to the opposite side. Where is the hemiplegia? The corticospinal tract again resides in the midbrain pons at the level of the medulla oblongata. It crosses and goes to the opposite side. So in a pontine lesion, eyes will be looking to the opposite side. Hemiplegia is also on the opposite side because corticospinal tract crosses the level of the medulla oblongata and then goes. So eyes looking to the same side of hemiplegia is a pontine lesion. Eyes looking to one side and hemiplegia on the opposite side is a frontal lobe lesion. It is because of the saccadic pathway, horizontal alignment pathway.
Thank you, sir. Dev, Dr. Jyoti has asked if you could please explain about the oculocephalic reflex and the mechanism of cows again. If you could repeat it once more.
I think, because it's such a fascinating topic, but it appears to be difficult if it is not well understood. But the moment you have understood the concept, you really enjoy the beauty of clinical neurology and the joy of clinical neurology. Basically, you have the frontal eye fields area number 8 and the vestibular apparatus, both trying to push the eyes to the opposite side. The frontal eye fields pushes the eyes to the opposite side in a fast manner known as saccadic pathway, whereas the vestibular apparatus pushes the eyes to the opposite side in a slow manner. How does it push the eyes to the opposite side? By connecting to the PPRF on the opposite side. PPRF connects the lateral rectus and the medial rectus through MLF, so it draws the eyes towards its side. So frontal eye fields and the vestibular apparatus both are connected to the PPRF on the opposite side, and therefore eyes move to the opposite side. So when you turn the head to the one side or when you pour warm water, you are stimulating the vestibular apparatus. When I turn my head to one side or when I pour warm water, I am stimulating the vestibular apparatus. So my eyes will go to the opposite side. That's why it's known as doll's eye movement. When we were children, we played with the dolls. When we turn the head to one side, the eyes goes to the opposite side. When we turn the head to this side, the eyes goes to the opposite side. Head up, eyes goes down, head down, eyes goes up. So when I turn the head to the opposite side, I'm stimulating the vestibular apparatus, so eyes go to the opposite side. This is it. But body always tries to maintain homeostasis. So when I put cold water, I'm inhibiting the vestibular apparatus. So this vestibular apparatus now will overact, will push the eyes to this side. But frontal eye fields area number 8 will try to push back to normalcy. So eyes go back. So warm, opposite, cold, cows, cold, opposite, warm, same. This is cows. Another interesting thing about the oculocephalic reflexes, to differentiate a peripheral cause of vertigo from a central cause of vertigo. Again, this OCR helps us. Central cause of vertigo, for example, Wallenberg syndrome, lateral medullary syndrome also produces vertigo. The vestibular apparatus also produces vertigo. In fact, in Wallenberg syndrome, vertigo is a prominent symptom because the vestibular gets affected, vestibular nucleus, the central part. But corticospinal tract is not affected because corticospinal tract is medially placed. So we tend to miss out. Since there's no hemiplegia, we think it's a peripheral cause. No, Wallenberg syndrome, a central cause also can cause vertigo because the corticospinal tract are placed medially. So when there is vertigo, clinically, how do we differentiate whether it's a central cause or a peripheral cause of vertigo? Again, this OCR comes into action. It really helps us. So when we turn the head to one side, the eyes goes to the opposite side. That's normal. So imagine I have this pen. I focus this pen and ask the person with vertigo to keep looking at the pen and turning the head to the opposite side. Normally, since my vestibular apparatus is intact and oculocephalic reflex is intact, when I turn my head to the one side, I still can keep focusing on the pen by turning my eyes to the left side using my OCR. So when I turn my head to the opposite side, I can still focus on the pen because I have normal oculocephalic reflex. But persons whose vestibular apparatus is affected, they cannot have the normal oculocephalic reflex. So when they are asked to focus on the pen and turn the head to the opposite side, but still looking at the pen, what happens when they turn the head? They cannot use the OCR reflex. So eyes also will turn along with the head. But since they are asked to focus, they'll have a catch-up second. So when you see this catch-up second, it's a peripheral cause of vertigo. That means oculocephalic reflex is impaired. This is known as head impulse test. Very important. So if a person has got that catch-up second, he turns the head, eyes also goes to the opposite side. So to look at the pen, he has to give a catch-up second. Whereas eye, whose vestibular apparatus is intact, OCR is intact, I can keep turning my head but still looking at the eyes because my oculocephalic reflex is intact. So this is known as head impulse test. So if head impulse test is present, the catch-up second is there. In fact, you have to be happy because it's a peripheral cause of vertigo. It's not dangerous. Peripheral cause of vertigo is not dangerous. Central cause of vertigo is dangerous. A brainstem pathology is dangerous. So if there's a catch-up second, head impulse test is positive, that means person's got peripheral vertigo. So we need not really worry. In fact, we call that as HINTS. Head impulse test, nystagmus, and test for skew deviation. So head impulse test is positive. It's a peripheral cause of vertigo. Again, this oculocephalic reflex is very useful to differentiate whether it's a peripheral cause of vertigo or a central cause of vertigo. When I turn the head and I'm not able to focus on the eye, I make a catch-up second. So a catch-up second head impulse test indicates a peripheral cause of vertigo. We need not worry at all. In fact, if there's no catch-up second, then one thing, peripheral cause of vertigo is not there, but then we cannot confirm, we have to further evaluate. But if there's a catch-up second, it's a peripheral cause of vertigo. Again, this helps. So doll's eye movement is a wonderful clinical examination, a simple bed test, but gives you a wealth of information. Very useful clinical test.
Thank you, sir. One more question we have is, can you please explain about the mechanism in locked-in syndrome?
Oh, very good. Why I always talk about this locked-in syndrome is, I read in a paper cutting that a woman who had cortical vein thrombosis postpartum, thrombotic state after delivery, developed this locked-in syndrome. But what really motivated me is that, going down and reading the further lines, it said that the woman with locked-in syndrome completed her PhD thesis with just using up and down movements using a code known as Morse code. Imagine a lady who is completely quadriplegic, cannot use her hands and legs, cannot move eyes horizontally. The only movement possible is vertical eye movement. If that lady having so much of deficits, but with strong determination could complete a PhD thesis with using a code known as Morse code, why can't we, with no deficit, perfectly healthy, achieve greater things? So this I always use for motivation and keep telling students. A woman postpartum after delivery developed thrombotic state, cortical vein thrombosis, locked-in syndrome, but she completed a thesis using Morse code with just up and eye movements. So why can't we? So what is locked-in syndrome? Locked-in syndrome, as I said, there are two types of eye movements. One is the horizontal eye movements. Second is the vertical eye movements. The horizontal eye movements, saccadic pathway, the quick movement, when someone knocks at the door, I quickly look, the quick movement, or pursuit movement, the slow movement. For example, I see a nice match being played, as I said, by Sindhu and some other star. I see the shuttlecock moving. So slow movements are known as pursuit movements. So these are horizontal movements, the quick movement, saccadic movement, or the slow movement, pursuit movement. The quick movement originates from the frontal eye fields area number 8 and goes to the PPRF from the opposite side, whereas the pursuit movements, it originates from the parietal lobe on the same side and goes to the PPRF. Here I also want to make a very important comment. The previous generation clinicians were very good because we did not have many gadgets or investigations. With just clinical application, they could diagnose. A person came with fever and a neurologist examined his eye movement, and he found that there was a decrease in the pursuit movement. So he said there is fever and the decrease in pursuit movement. We know that the pursuit movement, the pathway comes from the parietal lobe and goes to the PPRF. So parietal lobe is affected because the pursuit movement is affected and persons having fever. So fever plus parietal lobe involvement, it is a parietal lobe abscess. And to everyone's surprise, when they investigated, they found it to be parietal lobe abscess. That is the beauty of neurology. That is the joy of neurology. Another important point regarding pursuit movement is that you can differentiate whether the person is having true blindness or his hysterical blindness. This is known as optokinetic nystagmus. What is optokinetic nystagmus? For example, when you sit near the train window and you watch the scenery, you see a tree, you keep following pursuit movement. And once it goes out of your vision, there's a quick corrective saccadic movement. Pursuit movement, a corrective saccadic movement. Pursuit movement, a corrective saccadic movement. This is known as optokinetic nystagmus, which is a normal phenomenon, which is present in all persons who have good vision. So obviously, to test it at the bedside, we have to use an object at the bedside. So what we can do is that we can make a rotating drum with black and white stripes and rotate it. A person who is having hysterical blindness, for the reasons best known to him, for example, compensation, he may say, I'm not able to see, I'm blind. Then the doctor should say, no problem, even if you're not able to see, I'm just rotating the drum, just keep looking at it, though you're blind. So this person who is not aware of the scientific knowledge looks at the rotating stripes of the drum, but then he is not blind, he's able to see. So that what happens, he's got pursuit, corrective saccade, pursuit, corrective saccade. Optokinetic nystagmus is present. Presence of optokinetic nystagmus rules out blindness. The moment you see optokinetic nystagmus, you know he's not blind. That's just the beauty. So even if he says blind, since he's able to see the rotating stripes, his optokinetic nystagmus will come into force, and the presence of optokinetic nystagmus rules out blindness. A very important point. So in locked-in syndrome, so all horizontal eye movements, the center is in the pons. The midbrain, vertical eye movements, it is the center. You have up movement, up gaze, down movement. Up gaze, the fibers cross and then discern. That's why any lesion which is impinging on the top of the midbrain affects the up gaze, but spares the down face. Sunset sign in hydrocephalus. So in locked-in syndrome, there's a lesion in the pons, ventral pontine infarction. So it goes and affects both the PPRF, bilateral PPRF. So all your horizontal eye movements are affected. It affects the descending corticobulbar, corticospine fibers. So patient is quadriplegic, but midbrain is intact. The center for all vertical eye movements is midbrain, and therefore person can use this up and down movements. So presence of only vertical eye movements, absence of horizontal eye movements, and person quadriplegic, you call that as locked-in syndrome.
So how common is locked-in syndromes in clinical practice? Although it's a fascination very commonly for us, but is it very common in clinical practice?
Yeah, it is not very common. It is rare condition.
One question they've asked on clinical management is it mandatory always to intubate a patient if GCS is less than or equal to 8?
I think it depends on the clinical scenario. You check out on the oxygen saturation, his breathing pattern. I mean, there's no hard and fast rule. Yeah, usually you take 8 as a rough cutoff point, but then you have to look at other parameters and then decide for yourself. Oxygen saturation, the pattern, everything. But if you want to play it safe, yeah, you go ahead with intubation. You don't want to take chance or be heroic.
Yes. Another question is sinus bradycardia a feature of hypothermia?
Hypothermia, yeah, we usually see bradycardia, yeah. In fact, the brainstem reflex also get impaired. That's why we, in brain death, we always have to rule out hypothermia, especially less than 28, less than the core temperature, and then even drugs like barbiturates, because they impair brainstem reflexes. Yeah, it generally inhibits. Yeah, bradycardia is one of the features.
Yes, sir. Again, the same question regarding GCS. They've clarified saying Could you clear concepts when to intubate a patient with a saturation of more than 90 on room air with a GCS of less than or equal to 8? I think it's again, I think you've
Again,
answered the
as I
same, the
said,
clinical
again,
perspective.
you have to go for various parameters. The 8 is a rough cutoff point. There's no hard and fast rule. Oh, more than 8, yeah, you can be safe, and less than 8, you have to intubate. Nothing like that. 8 is a rough guideline.
Sir, could you add a word on commonly we use GCS. Recently, there was an update someone asked regarding GCS-P score.
Yeah, I'm not sure about that, but actually this GCS is basically meant for comatose patients with head injury. It started off with that, but then we started using GCS for all conditions of coma. But I think if you read textbooks and literature, they would always suggest to describe the person in toto. Instead of saying stuporous or drowsy, they would ask you to describe, like what happens when you pinch, how is his response. I think we have to be more elaborate than using a single worded definitions. And about this recent update, I'm not aware, I'm not sure. But basically GCS is for comatose patients because of head injury, one. And many clinicians are not happy with the GCS score because a person who's not able to use his eye, verbal movement, and there's no motor, no response, completely no response at all, how can we give 3 points to that person? But the minimum score in GCS is 3. So many people, many clinicians are not in favor of GCS because of this particular point, giving 3 points for a person who is totally unresponsive. So there's been a lot of debate to go for various other scales.
Yes, sir. Thank you, sir. I think that's the end of questions we have.
Yeah.
More of lot of gratitude for simplifying so many concepts for us, both on YouTube as well as on Zoom.
Yeah, thank you.
Sometime like we can have a session, sir, like clinical. Someone had requested if we can have a session on eye signs in stroke.
Yeah, actually, I was just thinking, yeah, we can have one on neuro-ophthalmology. In fact, one of my favorite topics. Second, I've been getting from a lot of students. They said there's a discussion on hemiplegia, there's a discussion on paraplegia, fine, sir, but we do not know the basic clinical concepts of hemiplegia or basic clinical concepts of paraplegia. For example, we just present a case of paraplegia, we just discuss and then go away. But what are the difference between conus and coda? What are the difference between extramedullary and intramedullary? How to approach a paraplegia cases? What are flexor spasm? What is paraplegia and extension, paraplegia inflection? So we need to have a basic clinical background for paraplegia and basic clinical background for hemiplegia. So if we know that, then it is easier to present a clinical case discussion. So I'm just thinking if we can plan, we can definitely plan one on neuro-ophthalmology. Second is basic clinical workup for hemiplegia, basic clinical knowledge for paraplegia. For example, I can give you one good example. Brainstem, very difficult to remember all the points. Very, very difficult. There are so many cranial nerves, so many structures, sensory, motor. But I'll just tell one small rule of 4. I think very interesting rule. You have 4 cranial nerves in the medulla oblongata, 4 in the pons, 4 in the midbrain and above, 2 in the midbrain and above. So 3, 4 in the midbrain, 5, 6, 7, 8 in the pons, 9, 10, 11, 12 in the medulla oblongata. Cranial nerves which can divide 12 into equal parts are placed medially. So 3, 4, 6, 12 which can divide 12 into equal parts are placed medially. Other cranial nerves are placed laterally. Structures which start with the letter M are placed medially, M for M, like motor pathway, like corticospinal tract, medial longitudinal fasciculus, MLF, medial longitudinal fasciculus, and medial lemniscus posterior column, motor part of the cranial nerves, all are placed M. M for M, medially and motor. Medially and tracks which start with the letter M. Sideways which start, and the tracks which start letter S, S for S are placed sideways, like spinocerebellar tract, sympathetic tract, spinothalamic tract, and sensory part of the cranial nerves like spinal tract of trigeminum. So if you have this clinical basic background knowledge, and then if you go ahead and present hemiplegia, it becomes very easy. And then rule of 17, 10th nerve and 7th nerve, they get affected. the movement will be towards the healthier side. And 12th nerve and 5th nerve, if they get affected, the movement will be towards the disease side. 12 plus 5 is 17, 10 plus 7 is also 17. So if you have some basic concepts, internal capsule blood supply, I feel is very, very important. Different vessels affect the internal capsule. So you have pure motor hemiplegia, pure sensory loss. Why? Because individual vessels supplies the individual part of the tract. Unlike MCA, which affects both, which supplies both motor and sensory. So you don't get pure motor hemiplegia or pure sensory hemiplegia and MCA too, but you get an internal capsule. So you should have such basic clinical background for hemiplegia and paraplegia. If time permits and if everything works out, I would like to talk about the basic clinical background knowledge for paraplegia, the basic clinical background knowledge for hemiplegia. Definitely you can plan, Doctor.
Yes, sir,
Very
definitely.
nice
Sir. I
suggestion.
think it would be very useful because knowing anatomy, without that, all clinical discussions, it doesn't make sense.
Yeah,
Very
just asking
important.
questions, discussing, and then going on. We should have the basic backup, the basic background understanding.
Yes, sir. I think that's the end of questions, sir. Thank you for enlightening us with your valuable time and simplifying so many concepts for us, which is seen day in, day out. And it requires a strong concepts for this. Mainly, as you keep stressing, concepts. So
yeah. In fact, my YouTube channel is named Dr. Sreenivas Medical Concepts. So I stress a lot of concepts.
Sir, it was indeed a comprehensive clinical class, sir. You look Dr.
Kishan, is it Dr. Kishan?
Yes, sir. You look at the comments in the YouTube, sir.
Oh.
So much of demand, sir, from the students for your classes in detail. They're asking for more and more. And today also they felt it is like it's not my own opinion. It's from a collective opinion from all the students who attended both in YouTube as well as Zoom today. They are really impressed with the presentation and the way you explained them and simplified the concept for them. And they are very eager, waiting for further classes, sir. And they're waiting for.
I am also very eager to present, sir.
Sir, advantage of having such good teachers is
by teaching, I'm learning. Actually, that's what I say.
Yes, sir. The advantage of having teachers like you is, sir, this request really, I feel 1 week of studies in books, which you made clear in 2 hours of lecture. Even after reading for days together, also we will not learn so easily from the books. But a good teacher like you will make it so simple, simplified, collecting knowledge from so many books put together, and in your own way, you presented in your own way and explained so well, sir. Thank you so much.
You're absolutely right, Dr. Kishan. You're absolutely right. Not all points are given in one book. There are good points in many different books. So the more books we read, the better concepts we get.
More than that, sir, it's from your experience, sir. You know, in whatever given in books are just theory, sir. But this is the theory plus your vast experience in the field. So you know what is good for students, what is not required for the students, everything you know well. And how can you make them comprehend, understand better?
Yeah. Again, I totally agree with you, Doctor, because I've seen so many students mugging up all the causes of coma. I just told them, any cause of coma, you can put in one of these 3 categories. And they were simply happy with that.
I always feel, sir, neurology is like mathematics, sir. If you understand the fundamentals, just with the symptomatology, if you understand symptomatology well, you can just make the diagnosis clinically. No need to go for any further investigation.
Joy of clinical neurology. Yeah. I think this is one specialty where with the good history, you can pinpoint the lesion, unlike other specialties.
Yes, and a lot of
history taking, where's the lesion? What is the lesion? You get the diagnosis.
Exactly, sir. Exactly. And it was mind-blowing session today, sir. Mind-blowing, really. Thank you so much.
Thank you for
we are looking forward for many more classes like this, sir, at your convenience. Please consider.
Sure, Doctor, we'll be in touch. Sure. And I have to really thank you from the bottom of my heart for a wonderful opportunity. And that too through the White Army. What I heard is that is one of the most popular platforms to address medical students across the country. So I'm indeed delighted to get into such good platform, the White Army platform.
And thousands of students will get benefited by your lectures because they may not have a good teacher in their own institute, maybe, but a teacher like you, will be the uniformly get to learn from the best teacher possible in India for a topic. So that's the advantage with White Army. We are blessed with the best of the best teachers in White Army. So
and students are blessed with the White Army, the best medical platform.
Thank you so much, sir. Thank you so much.
Thank you. So nice of you for your kind words. Thank you.
And thank you, Nitish, for also organizing this event. And thank you, Vijay Balaji, for hosting and moderating the session. Thank you so much. And we'll have many more classes by sir at his convenience. And members also can suggest neurology topics which you want in detail. Please, you can comment in YouTube comment section as well. And we'll have soon, next week, we may have a session on neuro-ophthalmology, which is again a favorite topic. And it's a very important topic for all, both UGs as well as PGs. Sir will definitely make the concepts very clear and simplified for our students. Thank you so much once again.
Thank you. So nice of you. Thank you, sir. Thank you.